today's session. And we're talking about prevention and control measures in avian influenza. I'm Georgette in the administrative unit of the infectious diseases of health emergency departments of PAHO. It's a pleasure to give you some administrative and logistics details for today. I'm glad to say that this session will have simultaneous interpretation in English, Portuguese, and Spanish. To access this translation service, just click on the icon in the lower part of your screen and choose the language you prefer. For speakers, we ask you to send your questions through the Q&A tab, and our team will try to answer as many questions as possible during the webinar. And now we will go with Dr. Angel Rodriguez, advisor in clinical management of infectious threats from the Health Emergencies Department in Washington, D.C. He will be leading the webinar today. Go ahead, Dr. Rodriguez. Thank you, Georgette, and good morning, colleagues. We are still waiting for some colleagues to join. We will be beginning at 9:05. I'd just like to thank you for your participation in this webinar to strengthen intersectoral responses to avian influenza. We will have people speak subject matter aspect from the CDC, from the United States, Dr. Christine Sobieski, veterinarian epidemiologist. And we will also have colleagues from PANAFTOSA, veterinaries who are in charge of intersectoral surveillance, Manuel Sanchez and Dr. Gabriel Torres. They will be talking to us about the responses to these outbreaks. And then we have a colleague from ASLACI, Dr. Torres, who will be talking to us about infection prevention and control measures in treating patients. This is the agenda for today. And we are just going to wait 2 more minutes and then we will begin with the webinar. We will start with an introduction by Dr. Andrea Vigari, the head of management of infectious threats from the Health Emergencies Department of PAHO. Good morning, Angel, and good morning, everyone. I'd like to welcome everyone to this webinar. I'm very grateful for everyone for taking their time to participate with us today. Influenza is of specific importance, not just because of seasonal influenza, but also because of the potential pandemic potential. And I think and I'm sure this has been an important topic in the whole region in the last few years. The risk of an influenza pandemic is always in my mind, and I think this is a fundamental point that we have to recognize. A pandemic influenza could come from another continent and could also start in our continent. It's important to recognize this, and I'm sure that in the last couple of decades, and especially the last few years, we've seen influenza activity growing in numbers of animal species. And I think this is something that highlights the importance of how we address this from an interdisciplinary and intersectoral point of view. And I'm sure that this is something that in the public health sector, animal health sector, and wildlife sectors need to consider. So it's important to recognize the presence of more viruses amongst more species throughout our continent, and this leads to the need to have this intersectoral connection. And it should have a purpose, and the purpose is early detection of any sort of animal-human propagation, and also early measures or the importance of recognizing initial transmission or the initial transmission chains that could happen with people who have been exposed to infected animals. And obviously, the role of the health worker as first line, as a first line, has a fundamental role. And so it's great to bring this topic to the agenda of infection prevention and control, where hospital services have a significant role. I'd like to thank everyone for their participation. I'd like to thank the colleagues from the CDC's participation. They have always been great allies, colleagues, and I am very grateful for their contributions. And I'd like to thank the colleagues from PANAFTOSA, which is a specialized animal health and public veterinary health institution, and Dr. Torres, who is going to also provide important contributions to this webinar. So thank you very much, everyone, and we go back to you, Angel. Thank you, Andre, for introducing the topic. Please remember that there's interpretation to Portuguese, English, and Spanish.
Perfect. And can you hear me okay? Great. Good morning, everybody. As Angel mentioned, I'm going to be talking about the HiPath AI H5N1 response from the United States perspective. So the first thing I want to point out is this is a One Health response. So there are multiple federal agencies involved in the response, including USDA, which is our U.S. Department of Agriculture, our ASPR, FDA, and NIAID through NIH. So all of them have played a role in this, but since I'm coming from the CDC perspective of things, the rest of the conversation will be around how CDC has responded and our role in this response. So CDC continues to support the U.S. government response to HiPath AI in dairy cattle and is the lead for the human health aspect. We have four main focuses. First is supporting and engaging public health and agricultural partners at the local, state, and federal level. Protecting human health and safety by helping states stand up monitoring and testing programs for people working with infected cattle, and assuring they have the information and resources they need to prevent infection. Understanding the risk to people from H5N1 through epi studies, and identifying ways to prevent additional cases. And finally, by assessing influenza viruses in people, influenza H5 viruses in people and animals for genetic changes that could indicate the virus is adapting and could spread more readily to and among people. So a little overview of HiPath AI virus. The type of HiPath AI that we are seeing, which is H5N1, was detected in birds in the wild in China in 1996 and resulted in poultry outbreaks and human cases. Since then, H5N1 viruses have circulated in wild birds and have undergone genetic diversification. In 2020, a new clade or type of H5N1 virus emerged, which we call clade 2344B, and that began to circulate in unprecedented numbers in wild birds globally. So in the US perspective, at the end of 2021, we started to detect the 2344B viruses in wild birds in North America. In February of 2022, we started to see spillover into commercial and backyard poultry. In March of 2024 is when we detected it first in dairy cattle. And then in April of 2024 is when we had the first human case of H5N1 associated with dairy cow exposure. Now, globally, the virus has continued to become widespread, causing record numbers of outbreaks in wild birds and poultry, And then in the preceding years, 2024 and 2025, we've seen it affect livestock, particularly in dairy cattle in the US, but has affected a couple other livestock species. We've seen some alpacas, goat kids, and then UK also detected it in sheep. I want to emphasize that sporadic human cases of H5N1 have been reported over the years in 23 different countries since 1997. And unfortunately, the case fatality proportion has been greater than 50%. So if you look at the total number of cases over the years, only a small number of those are occurring now. From the US perspective, prior to 2024 in our outbreaks in dairy cattle, we only had one US case of H5N1 that was reported in Colorado, and a person who had direct exposure to poultry and was involved in a culling poultry that were presumptive positive for H5N1. Historically, human infections on the previous graph have been a result of poultry exposures from direct or close contact with sick and dead poultry, or visiting a live poultry market, or exposure to other infected animals such as swans, or most recently, dairy cows. And we have seen limited, non-sustained human-to-human transmission in other countries in earlier outbreaks, generally in family members caring for sick loved ones, but we have not seen any human-to-human transmission in the United States. So on the human health side of things, I'm going to just talk about our current outbreak, which is the 2024-2025 outbreak. There have been 70 confirmed human cases, with no new cases since February 14th of this year. And so of the 70 total human cases, there have been 41 cases that were due to exposure to dairy cows, 24 cases that were due to exposure to poultry depopulation enterprises, 3 cases with no known exposure. So one of those was in Missouri and 2 were in California. And then 2 cases due to backyard flock or wild bird exposure. We had 1 in Louisiana and 1 in Wyoming. The person in Louisiana who experienced serious illness was hospitalized and passed away in early January, and that is the only H5 fatality in the United States. So overall, CDC still defines the risk to public health as low, but we do recognize there is a greater risk for people with close, prolonged, or unprotected exposure to H5 infected animals, or the environments contaminated by infected animals. And we do recommend that exposed individuals should be monitored for symptoms after their first exposure and for 10 days after last exposure. So since March of 2024, CDC has been working with our state and jurisdictional partners to actively monitor for additional cases of H5N1 among individuals who have high-risk occupational exposures. And through this targeted monitoring, we have monitored over 16,700 individuals, just following them up over those 10 days to make sure they do not develop symptoms. If they do develop symptoms, then we refer them for testing, and over 880 persons of that 16,000 were referred for testing. And of those 880 that were tested, 64 human cases were detected as H5 positive through this active targeted surveillance. And as you can see from this diagram, we have a mix of persons who were exposed to cows as their infection source that required monitoring. And then we have people who were exposed to poultry, wild birds, wild mammals, rescue cats, zoo animals. Other persons fall into a different bucket of almost 7,000 people that were monitored through exposures outside of dairy cow infections. And then from those who were tested, as you can see, most of the people who ended up developing symptoms and being tested were ones that were exposed to that other animal category. CDC also has national flu surveillance and has been coordinating with public health laboratories across the US to monitor and test for influenza viruses. And through routine surveillance since February of 2024, more than 192,000 samples have been tested using this protocol that would have detected H5 viruses if they were in the population. And we did identify 6 more cases through that national flu surveillance. We also are utilizing wastewater surveillance. These are capacities developed at CDC and in states over the last few years via the National Wastewater Surveillance System. And we receive weekly influenza A and H5 data from academic partners, about 150 sites, and some state health departments. So these data may complement existing influenza surveillance systems. Now, I do want to put in a caveat that wastewater surveillance doesn't distinguish between animal and human inputs into sewer systems. So CDC staff on the H5 outbreak response work with state and local public and animal health partners when there are reports of high influenza A or H5 detections to track down those sources in those systems. So we'll shift now a little bit to talk about some clinical findings. And I know that we're going to have a more extensive clinician to talk a little bit later on. So I'll try to breeze over these a little bit. But worldwide, clinical findings are either mild illness or progression to lower respiratory tract disease. So for most of our cases in the United States, we have been on the mild illness side. So fever or feverishness, non-productive cough, muscle aches, malaise, headache, sore throat, myalgia, maybe some abdominal pain with vomiting and diarrhea. In the United States specifically, we've seen a lot of eye discomfort, redness, discharge, what we call conjunctivitis, which occur about 1 to 2 days after exposure. If it does progress to lower respiratory tract disease, we see that about 5 to 7 days after symptom onset, and that can progress to difficulty breathing, shortness of breath, chest pain, tachypnea. In hospital admissions, from a clinical perspective, you might see hypoxia and signs of pneumonia. From the laboratory side, you might see a leukopenia, lymphopenia, a mild to moderate thrombocytopenia. We have a couple of radiographic findings from the side. That's from a publication from about 20 years ago, so one of the earlier outbreaks of H5N1. But you can see bilateral pneumonia with patchy, interstitial, lobar, diffuse infiltrates, opacities, and consolidation. Pneumonia is the most common complication, which can progress to respiratory failure and acute respiratory distress syndrome. Community-acquired bacterial co-infection is rare, but you can see ventilator-associated pneumonia if your patients are intubated. And then other complications can include acute kidney injury, sepsis, shock, disseminated intravascular coagulation, or multi-organ failure, cardiac failure. And you can also possibly see encephalitis or meningioencephalitis, Bray syndrome, spontaneous abortions. These don't happen quite as often. So if an H5N1 virus infection is suspected, we recommend wearing full PPE while collecting samples, and patients with acute respiratory symptoms should have 1 nasopharyngeal swab and 2 combined nasal and throat swab specimens. Place each specimen in separate tubes of viral transport media. And if your patients have conjunctivitis, collect a conjunctival swab and a nasopharyngeal swab, putting those into separate tubes of viral transport media. Influenza A testing is usually done at a public health laboratory. Many clinical tests might not be able to differentiate between H5N1 and seasonal H3 or H1 viruses. So you need to be able to perform specific subtyping for H5. If you do have persons who are hospitalized, we recommend infection prevention and control measures. So place a patient in an airborne infection isolation room with negative pressure if possible, and recommend wearing PPE when around that person. So gowns, gloves, NIOSH approved N95 filtering, face piece respirator, and eye protection. And if patients have lower respiratory tract disease, in addition to collecting the upper respiratory tract specimens discussed in the previous slide, we also recommend collecting a sputum sample. And if you have an intubated patient, you could also collect an endotracheal aspirate specimen or a BAL fluid. If you collect multiple specimens from multiple sites over multiple days, you're more likely to detect the virus and maximize potential for diagnosis. As far as treatment, oseltamivir treatment is recommended as soon as possible for patients who are suspected, probable, or confirmed cases of H5N1. The current H5N1 clade 2344B viruses are generally susceptible to oseltamivir, so that has been our recommended antiviral of choice during our outbreak. observational studies suggest that there is a survival benefit the earlier you start oseltamivir. So at some point there becomes a waning benefit if you wait too long into this course to start your oseltamivir. And that's another reason that we recommend going ahead and starting oseltamivir, even if the case is suspected or probable before it's been confirmed. Don't wait on laboratory testing to start antivirals. If you have a high known exposure and they are starting to develop symptoms, go ahead and start the antivirals. And I kind of already explained that. If you have somebody who is a household or other close contact that has symptoms, that has a health portfolio that a clinician feels that they might be at higher risk for developing H5N1 serious complications, you might decide to recommend starting post-exposure antiviral prophylaxis. And that would be between them and the clinician and public health deciding it together. So back to a little more of the other things that CDC is doing in addition to our active response to human cases. We are doing virus characterization. So CDC has conducted genetic sequencing of viruses from human cases when feasible. And we have found that sequencing results identify clade 2344B for all of our cases, which is the same clade that's been widely circulating in birds, US poultry, and cattle. And importantly, the available current information indicates that 1, current diagnostics are able to detect the virus. 2, in influenza specimens from 3 of the Washington H5 cases, so 3 of our 70 cases, CDC did identify mutations that may slightly reduce susceptibility to oseltamivir. But it is important to note that this change is not spreading widely in H5 viruses. And the change is not expected to have an impact on the ability of viruses to replicate or spread more easily. While this change may slightly reduce antiviral susceptibility, it is not the same as resistance, and is unlikely to have a meaningful impact on the clinical benefit of oseltamivir, which is our currently recommended antiviral treatment. CDC also identified a different change in the polymerase acidic protein of the virus collected from an H5N1 bird flu case in California. So this change is associated with decreased susceptibility to the influenza antiviral medication baloxavir and has been sporadically detected in a small number of avian influenza viruses. Baloxavir is not currently recommended for treatment or post-exposure prophylaxis, but it's something that we are monitoring. So in summary, although these particular changes have not been detected widely and are not spreading among dairy cattle or birds, these findings underscore the importance of ongoing surveillance and testing to analyze H5 viruses for any changes that could potentially impact their susceptibility to flu antiviral medications. And lastly, the virus is very closely related to 2 existing H5N1 candidate vaccine viruses, which could be used to make a vaccine if needed. And that's a human vaccine if needed. CDC has also collaborated with some partners on some seroprevalence studies. We collaborated with states of Michigan and Colorado to conduct serosurveys in farm workers. 115 people who worked on farms with cows infected with H5N1 participated in this study. 8 of these 115 people, or 7% of participants, showed evidence of recent H5N1 virus infection, and 4 of the 8 with evidence of infection did not remember feeling sick or showing symptoms. So this study added to the data that CDC had reported in July of 2024, which described early results of the first phase of a study among 35 workers in Michigan. And that group of workers, none showed evidence of prior H5N1 virus infection. And 80 more workers were included in the second phase of the study in both Michigan and Colorado. So identifying some workers who did not recall feeling sick, but who had evidence of recent H5 virus infection is important new data that informs guidance for us and how we offer guidance to protect workers. And then most recently, CDC collaborated with Ohio and the American Association of Bovine Practitioners, which is our national organization for cattle veterinarians. And we tested serum from 150 individuals using 2 serologic assays. 3 individuals, or 2% of the study, tested positive for recent H5 infection. 2 out of 3 reported having cow exposure, and 1 of 3 reported having poultry exposure. None of them recalled symptoms, and none wore face or eye protection. This will likely be of interest because detection of antibodies in people with no symptom recall and lack of appropriate PPE is important. Additionally, in one positive individual did not work in a state with known animal detections at the time of the survey, raising the need for faster, more systematic detection of positive herds. So currently, based on the data we have available, the overall risk to the public remains low. However, as we stated, people who work with or have subsistence or recreational exposures to H5N1 virus-infected animals are at an increased risk of infection, particularly if they are not wearing appropriate PPE. Therefore, we always recommend a readiness posture for national influenza surveillance, assessing the genetic changes, and evaluating impact to current diagnostics, treatments, and candidate vaccine viruses. CDC will continue to work with our local, state, and federal colleagues to conduct public health surveillance and monitoring for concerning changes in the epidemiology of human cases or changes to influenza H5N1 viruses that could signal an increased public health threat. We are continually evaluating risk based on the newest data and ongoing risk assessments to the public's health and the risk for pandemic emergence, such as utilizing our IRAD tool. And then, as I said, we will continue to move forward with a One Health posture of collaborating with state public health and agricultural partners, as well as with other US government agencies. And then there's a little bit of some information and slides to look at other places that we put some of our information. And that is all. So I'll stop and see if we have questions.
Colleagues, just jot down your questions, or if you would like to do this verbally, or please write them down on the Q&A for Christine and other colleagues from the CDC. Now we continue with the other presentations in the seminar. The next presentation will be given by our colleagues from PANAFTOSA. This will be a joint presentation between Gabriel Torres and Manuel Sanchez. They are in charge of epidemiological animal surveillance of avian influenza, and they are going to talk to us about an intersectoral response. We're going to start with Gabriel, and then we will go on to Manuel Sanchez. So go ahead, Gabriel. Hi, good morning. Good morning for the invitation. I'm going to share my presentation, and please let me know if you are able to see it. Perfect. Thank you. My name is Gabriel Torres. I work in the PANAFTOSA Center. I would like to thank the colleagues from PAHO and Manuel Sanchez, my colleague from PANAFTOSA, that invited me to talk about the response to cross-border diseases in animals. I'm a specialist in foot and mouth disease, but their concepts and their principles and strategies for a cross-border disease are the same as a regular one. So we can use in our experience in foot and mouth to talk about avian influenza and other diseases. Unlike human diseases, many times we control cross-border diseases, animal diseases, because of their impact, economic impact, or animal mortality, but not a focus on human health. And this is what happens with foot and mouth. It's not important for human health, but it has a lot of economic impact and a lot of impact on producers and high levels of morbidity in the animals. And for avian influenza, it's a little different. Avian influenza has that aspect of human health. Therefore, it's a disease that we also control because of human health and not just because of economic aspects. So I'm going to talk about these 6 topics. We don't have too much time, but I will give you a brief introduction, and I will talk about how to fight an animal disease from the veterinary authorities' point of view. We're going to talk about the goals in a response, principles, strategies, the operation center, that is a fundamental entity in animal health, and a little bit more about later actions. So it is important when we talk about animal cross-border diseases, and we have influenza and others, that the response is not a small part, but it's just one part of the cycle of the disease. We have a prevention stage to avoid transmission, so we have cross-border actions and pre-border actions. Many times these include agreements for import of animals or genetic material. There's border actions in the airports, for example. All countries in the continent act this way. There's actions in dry borders or ports to avoid the entry of animals or products that could be carriers of the disease. Then we also have to prevent exposure for people, and especially for poultry. Biosecurity has a very important role. So when we talk about avian influenza, it's impossible to control migratory birds, where they're going or where they're coming from, but we have to avoid contact with production or domestic animals, their contact with these wild birds. So security has a very important role. And if the disease exists, we have to be able to have early detection, and early detection goes through the producer, field veterinarians, and those who are in direct contact with the animals, and that should be able to recognize clinical symptoms of the disease. They should know who to notify, and they should be interested in notifying. This is important, and this is something that we should discuss. If the people are sufficiently interested in notifying. This will depend on the private sector, and then confirm the disease. This will depend on the public sector. We need to have a reference lab or be able to send labs quickly and adequately to a reference lab. Once it's confirmed, we're going to talk about that today, and that is to have a fast and efficient response to look for business continuity measures. When we talk about emergency actions, contingencies, and cross-border actions, these should be considered within contingency plans. The countries in the Americas have their own contingencies plans. Some have more than one plan. Some have a general plan for emergent diseases and specific plans by disease. And this is a good way to work. There's other countries that only have specific plans, but it is important to have a description step by step of what should be done. We always have some space to be creative. When we're facing an emergency, we will see situations arise that we hadn't considered or foreseen, but mostly everything should be written down, and we should follow those steps, and those steps should be included in contingency measures. And these are documents where we describe objectives and principles of the strategy and structures that are necessary for emergency access, planning and execution of considered actions, and some key questions. What to do, why, where, and geography is basic in cross-border illnesses or diseases. Also, time is a key factor. Who and how? What are the methods that we're going to choose? We have to learn the dimension of the program. So this is a program that is restricted to geographic space, and that way we need to contain the disease in the smallest
We're
space
able
possible.
to see here in reference to the lowest amount of time to be able to reduce social impacts, and sometimes in reference to being able to see here the impacts of public health, and specifically in reference to being able to identify and to be able to eliminate the outbreaks of illnesses and also to eradicate this is the final objective to be able to have a risk management in reference to the continuity of the activities in reference to being able to see a clear level. We're going to have some kind of interruption. Some animals will be sacrificed. Some products are going to be distributed, but we need to have a continuity plan for business. So the main principles involved for any illness in reference to the whole contingency plan, it needs to be able to consider these principles. First of all, to be able to interrupt the production. That is the quickest manner in which we are finding right now to be able to eliminate infected animals. That is a discussion that has been quite long because today there is a higher resistance on behalf of the society in having massive sacrifices, but in some ends, we must do this, and this is the most efficient manner that we have to be able to interrupt the dissemination of this. Also to prevent contact between animals and people. And here we're talking about the importance of the visibility, specifically in agriculture, where there is already a concept and a culture that establishes bio safety in farms for other parts here. We see that this, we are not speaking much about this. It's not as disseminated, but in case of birds, it is something that all of us have in mind to be able to reduce the number of animals with direct risk of infection. That can definitely mean the sacrifice of healthy animals, which is a possibility. Some animals are also some countries are seeing this possibility, and also when it corresponds it, and it, of course, it is always going to be possible because here we are talking about in a general manner of these kind of illnesses to be able to interrupt the transmission by vectors in avian influence. It's not an issue, but for example, in other ends, this could be an issue. We can have the transmission of illnesses, and also when we need to have we have people that are located in populations of wild animals. It's very difficult to be able to have an intervention here. But again, using the example that we have previously seen, we can use it for specific animals. Continuing here, okay, well, these are the strategies which in a general manner are used to be able to fight these illnesses. First of all, a quick identification and elimination of outbursts. Many times here we use the sacrifice, and we need to remember that sacrifice, sanitary sacrifice, according to the guidelines of the animal or the health organization, it's not only about sacrificing the animal, it's about eliminating all channels and cleaning and disinfecting. This is an action of 3 stages in a mandatory manner. And then we can work with the different parts, but that's specifically afterwards when this establishes that the illness was eradicated. It's not something that is done at a first step, but at first, it is very important to work with zonification. We're going to see some examples. Zonification passes in reference to the definition of an initial area of emergency, and this area is divided in risk areas. So here we have In a general manner, we're going to see some examples, but we divide the radiuses, and in reference to having this part, each country uses this for each one of these ends, but these are radiuses of risks that are different. And therefore, for the radiuses that are closer to the outbreak are of higher risk, and they require actions that are considered to be more firm and solid. And also the most affected radiuses are radiuses of a lower risk. Here we have a little bit more flexibility. We're going to see here some examples soon. And in this area of emergency later on, we're going to have this transformative contention area. We are going to be speaking more about this area of contention. Other important strategies to be able to restrict here to be able to restrict and control the movement in the areas of emergencies. The epidemiologic investigation is done to be able to identify new outbreaks and to be able to establish the primary one. Many times it's difficult, but we try to do this, and therefore the properties in which we try to inspect and make the investigation are properties in reference to being able to see the different radiuses that we previously mentioned in reference to the different areas of risk. And of course, when there is an outbreak, we carry out an inspection more frequently based on the incubation period of the illness. So if we are going to a property that is 2 kilometers from this outburst and we don't find anything, we don't find any of this, then we need to go back to a period of time, and if it's closer to the outbreak, the amount of time is less. So we can see it every 3 days, every 7 days, every 10 days. And it is definitely going to have a variation. And also to be able to track this in reference to 2 times the time of incubation of the illness calculated previously in reference to the probable beginning of the event, security and safety according to the different areas. We need to be able to improve this in reference to the staff that works is going to see these parts. The veterinarians are able to see these outdoors, are able to inspect more than one, and therefore it's important to change the clothing to have actions in a general manner, and always in communication and education and social communication that is important. It is a continuous action, not only in the moment of the emergency. In the moment of emergency, we have characteristics for the season, but we need to have a continuous action in reference to this, and also here vaccination, which is also a tool that we are going to be discussing here. The indemnization of producers is important. I understand that there are countries in which there is not the indemnization, or for which there are for some illnesses and for others there aren't. And that is why it is important that the public and private sector are able to discuss these points. It is important that there is a way of gathering funds, collecting funds for the indemnization. These funds can be public or they can be private as well. We can put different rates to be able to issue permits for mobilization. And we need to be able to discuss, and we need to be able to have funds. That is what is important, because if we do not have these funds, then we will have what we mentioned before. In what way the producer is going to have the interest of notifying if they know that the animals are going to be sacrificed and that they're not going to be compensated. That is something very important, and it's something that we need to be able to be seen by the countries. Also, the preventive sacrificing is not as common. It is not usually done, but it is also a strategy that needs to be considered to be able to reduce the quantity of animals that are seen in the area of emergency, and the control of reservoirs and vectors in reference to the illnesses. And these are always important and feasible, but of course, this can also be considered a strategy. I'm not going to go into more detail, but those are the strategies, and we need to be able to see these strategies. Some of them are mandatory, of course, in reference to the increase of biosecurity. We are not going to stop doing this communication, education, but sometimes we can choose to sacrifice or not. We can choose to use the vaccination of emergency or not. There are criterias that take us to be able to guide onto the decision. There are many criteria that we need to consider. I will not specify all of them, but we need to be able to see the production, the species that are involved, the number of outbursts that we are finding, characteristics of people, the different physical barriers. There are many things that are involved when talking about choosing strategies to be able to have this kind of illness. And another one that is important is the emergency vaccination that can be used. And here we need to be able to remember that the action of a routine vaccination is different. A vaccination that we use to be able to protect the animals of a country or of an area or of a region, that we are able to do this annually or each quarter. And we're not talking about this or the preventive manner. Normally, this is done in reference to an area of borders or there is a high risk, and we try to choose this part in reference to the vaccination, but this is not the principle of the vaccination of emergency. The vaccination of emergency is used in as a response to one or more outbreaks and always around the infected unit. This is one that is done by the official veterinarian service in reference to this part, and it's always going outside of the area of emergency and it gets closer to the outbreak. Now, it is not a mandatory strategy. What factors are influencing this? There are many factors that help us decide whether we use an emergency vaccination or not. We are not going to have time to discuss all of these aspects, but some of them are very important. We have availability of the vaccine. We have a bank of vaccinations. How long will it take for us to be able to have access to the vaccine? And when will it be available at the point where it's going to be used on field? What are the characteristics of that vaccination? If the immunity is quick after its application, if it takes a little bit more of time. In other words, it's going to very much depend on time. If we are not able to do this in a quick manner, maybe this loses all sense. We need to be able to have a good characterization of saying what kind of virus it is, because we can have a vaccination that is different than the one on the field, and if the animals are not going to have a good response, we need to be able to see the structure that we have of the staff to be able to execute the vaccination, the density. I mean, there are many aspects that the service needs to be able to consider to be able to use this emergency vaccine or not. The limitation of an emergency area, like I mentioned at the beginning, here each country uses a term. I think this is very much important. But for example, when talking about the example in the left in Brazil, in Brazil we have the outburst in a radius of 3 kilometers around. They're talking about around 10. We call this the surveillance area, and plus 15 in around 25, the area of protection. In the middle, we have a real picture of the outburst that we had here in reference to avian influenza. Here we only use the radius of 3 kilometers and the radius of 10 plus 7 plus 3, which is a surveillance area, because in the contingency plans of Brazil, the protections area are optional. Of course, it's not mandatory. Therefore, we decided to not use a protection area, but here the population has already all of the areas, and if it's closer to the outburst, then we are able to work in a area in reference to these actions to, let's say, we were able to work with some time of inspection to the properties that are shorter every 2 days, every 3 days, and we also work with biosafety that is seen here in reference to transit of animals, a series of actions. And of course, here we are able to see the emergency area that was able to be established by the European Union. Where here we have different radiuses of 3 and 10 kilometers added all together, the protection area or surveillance area. The name does not matter. It varies according to the countries. Or what is important is that we have the area of emergency determined and defined. We need to be able to understand that these are radiuses of levels that are differentiated, that we need to be able to work here with differentiated actions. And this area of emergency is going to be transformed at a moment it is going to evolve toward a contention area. The contention area is not an initial strategy. It's a strategy that is going to arise afterwards. Why? Because it is necessary that we have 2 periods of incubation for the illness without the occurrence of illness in at least a part of the contention area. So here, the initial area is going to evolve to be transformed, and the contingency area, the contention area is included in the Article 4.4.7 in the code of the Animal World Health Organization. We here have all of the definitions and all of the points. We're not going to have enough time to be able to see all of the rules, but all of these are placed by the codes, and the contention area is just in reference to an affected area within a country or a previous free area. Previously, the whole country or area is going to be affected, and here the country needs to be able to see this in the contention area, needs to create the contention area, needs to require to the health into the Animal World Health Organization to be able to determine certain factors and certain principles that we're not going to be able to discuss here. The whole country becomes a whole free area, and the zoning is only for this contention area. Therefore, there are two models. The model on the left, which is what we have here, in which we are able to have the contention area. And also the country needs to be able to guarantee that in this contention area, for 2 times the period of incubation of the illness, there were not new cases. And the other part, the model on the right here, where there is an internal area that is in red, in which we still have outbreaks. There are going to be new outbreaks, but the country guarantees that in the external yellow area, there are not any cases throughout at least 2 times the incubation period within the scenario or a free area. This is the concept that for some years we've already had in the code, and that people and countries are using. For example, Germany previously used this to be able to see a specific illness because they required a contention area, and then the country chose the certification of a country free without vaccination. Here we have how we work in reference to a center of operations. We've understood that many times official veterinary services are not prepared to be able to work in a case of an emergency, maybe as other structures are in the country. There are structures. Each country has its specific structure to be able to work in emergency situation, general emergencies. We are not only talking about illnesses of animals or any kind of emergency, a hurricane, a flood, any of these things. And the experience tells us that we need to be able to work together with our agencies or institutions that work with emergencies. And more than just that, we need to be able to adapt the structure to the structure that they are using. They are using a tool, a methodology that is the system of the commands of incidences, which is a methodology that is known worldwide. It is used worldwide, and we've been able to learn with our own experience that we need to be able to use this tool. This tool proposes the forming of a command of a center of operations in the place of the incident, in the place of the accident, the incidents that has the structure that we have here. For example, there is a unique command of the incident with some of them that we call the official ones that are going to help to be able to manage the incident. And we basically have 4 coordinations. One coordination on the field that is going to be able to execute the field's actions. One coordination for planification that is going to be able to coordinate everything that has to do with the planification in the field. This is a very important principle of this part to be able to separate this from execution, a logistic coordination, a financial administration coordination. And all of this is the basic structure of an operation center in the command of incidents. We, as a part of this, are reviewing all of the contingency plans in some countries of the continent, and always we are proposing that we are able to have a center of operations with a base in this structure, which is a structure seen in reference to this center command of incidences. Here are some operation centers that we use in Brazil. The center of operations needs to be, well, it could be any place that has a minimum structure that has electrical energy, that has water, that has internet. We can use public, private institutions. We can use school. We can use anything that is able to assist our needs, the needs of having in our center of operations. Here, we're able to see 2 center of operations and 2 outbreaks in the year 2000. It's very important to be able to see here. I don't know if you know the state, it's in northern of Brazil. Here we have the Amazons, and here basically here we are able to use these ships as a center of operations, and that's perfect because this goes according to the command center of incidents that mentions that we need to get adapted, and we need to adapt to the situations and the different local characteristics. And at that time, the adaptation was to be able to create the center of operations and ships, which is something completely viable. In some future actions, these were the initial actions that I discussed, but of course, some of them would continue. Some of them must be maintained throughout the whole emergency. The production, analysis, and use of information in reference to the epidemiological center, new outburst, investigation, tracing, and there are, of course, many others that we can discuss here throughout the whole morning. Then after this, we are able to have these outbursts eliminated, and we are able to generally see this throughout twice the time of the incubation period. We can use sentinel animals. There are animals that have not been exposed, and we are able to verify here if the space is clean and disinfected and free of the agent, because we keep these animals and these animals are monitored, and they are monitored serologically, virologically, to be able to determine if there's or just an infection, if there is any viral transmission. And after that time, to be able to take status, the restitution of statuses is going to have a variation from illness to illness. In a general manner, the recommendations are in the code. There are recommendations of the Animal World Health Organization that respond to 2 maximum periods of incubation, and therefore that would be the minimum period to be able to obtain the status. And in the case of avian influenza, for example, 28 days. In the case of the African porcine, it would be 20 days, which are about 2 incubation periods, but depending on the capacity and the grade of if it is an agent that is very much infectious, if we need to be more careful here, we're also able to change this period. And therefore, for example, this here, the Animal World Health Organization understands it's minimum 3 months, which is what Germany has done. Germany has had it outbreak in January, and I believe that for May and April it was almost 3 months. And here we are able to see the contingency area already detected, and then the rest of the country, I think in May, the complete country was completed as of spring. Well, that is what I wanted to mention. Hopefully I didn't take much of your time. It is very important, but I am here, of course, to be able to answer any question. Once again, to be able to thank the Animal World Health Organization for discussing these very important aspects. Thank you very much. Thank you, Gabriel. Thank you very much for this presentation. Thank you very much because you gave different examples of different illnesses. And now we're going to be able to complement this presentation with Joel Sanchez, advisor in animal epidemiology, and he is the person in charge of avian influenza in birds. Okay, can you hear me? Yes, yes. Angel, Milen is now going to give your presentation. Hi, yes, thank you very much. I'm just going to show a couple of slides, not many, so we can actually put this perspective in um, in the context of avian influenza. Now, just to be able to contextualize this, when Gabriela was talking about the contention area, this very much has to do from the perspective of animal sanitation, which what has to do outside of this contention area. It is assumed that it is free. I am not yet seeing my slides, my presentation. I don't know if, no, it's not there yet. We're not able to see it in Washington or Santiago de Chile. I'm in Temuco. Temuco, yes. Just one moment, please. One moment. No, it's fine. It's fine. Okay, but while we wait for that, we have this contention area, which is a concept that is very much linked to commerce and trade. And this is what we were actually trying to see in the presentation of Gabriel, which was about having this perspective of when we start working again in this official veterinarian services, we have this main concern in reference to this part, and also in reference to being able to recover the commerce and the trade and the impact that the production has in reference to these outbreaks. I'm sorry, you're able to get that. One moment, please. The computer. One moment, one moment. Apologies, one moment. No, it's fine. And then in the part of the investigations, which have already been seen in many countries, this part here is the services given by the official uh, emergency services are many times coordinated with the health sector, recovering information that is going to be necessary from the part of public health in reference to people being in contact, etc. You can go directly on to the other slide. Well, here we are able to emphasize that we can actually see here in reference to the purpose of production. It's important to be able to see that the responses given by the official veterinarian services and the private sector has to do with this concern in reference to this cost of production, given the high morbidity and mortality in reference to what we have here, and this and in reference to the production of eggs. We have this response. Obviously, it's very much expensive, and this is very much applicable in reference to what Gabrielle was mentioning. Here, the costs associated to the services of elimination and indemnization. But here, there is a way in reference to being able to see that every time there is an outburst of avian influenza in a country, there is a response from third-party countries in reference to the closing of trades and commerce. And this very much has to be do with an impact that is much more important. These indirect and reference services are also important. The next one, please. I wanted to contextualize this starting from the perspective that in the animal and this is an illness that is very much concerning from the point of view of production, reproduction, and economy. It is also important to establish when we talk about animal health, we're also used to talk about this avian influenza of high or low levels. Here we are able to see pathogenicity. And traditionally speaking, this has to do with the impact in reference to what this uh, this illness has specifically in its chickens, talking about mortality and cause of mortality. And in reference to the concern that we have in reference to being able to see this official veterinary service and also from the Health World Organization has to do with this high level of pathogenicity. The one of low pathogenicity is only going to be seen when it is related to H5 and H7 subtypes. This has to do with the fact because in reference to all of the viruses of high and low levels have been associated to this parts, and also in reference to the capacity of this service, we are going to be able to see at the H5 or the H7 of low pathogenicity, and they're transformed in high pathogenicity. And this is in reference to what we are able to see from health for animals. In the following slide, as we are able to see, we can see that from the perspective of public health,
We have other concerns, and that is because the H5 and H7, in terms of high pathogenicity, is related to a different behavior, but it's not duplicated in the same way. We can have a high mortality in laying chickens and low mortality in turkeys, for example, and this is transferred to other wildlife, birds, mammals, and so on. And that's why the behavior will be different. And so in public health, there is a concern about other subtypes like H9 that has a high pathogenicity behavior in birds and therefore doesn't require mandatory notification in OMSA. And just to show that we are in two parallel worlds, we have the surveillance concerns and then the economic concerns versus public health. And of course, public health is the impact on human health. Next. The sectorial concerns. I'm going to show this very fast. We have public health, and this is the concern on the impact on people. We are concerned about high and low pathogenicity influenza and pork influenza that doesn't have a mandatory notification for PAHO. So we have to be concerned about what should happen. We have to prevent pandemics and outbreaks that can affect people. Now, when we look at official animal health, this is in charge of high pathogenicity, the H5s and H7s that need to be notified. And we have to show the status. We have to show the absence of this disease in the bird populations in the country. So we have to do surveillance, control, and response. Then we have the animal sector. These are the producers that focus mainly on the, well, commercial farms. This is an integrated industry where you have the genetics and all the way down to the farm and the slaughterhouse. They're all part of the same structure. And then we have the environment. And they have the very important role, and we're still defining and consolidating this in most countries. And this role or the sector is concerned about biodiversity, about conservation, and they also have a role regarding surveillance of wild populations and also in emergencies, we also can talk about eliminating bodies or cadavers. Now, we have some common aspects that are of interest to every sector. So the risk context right now in the region and the role of birds, mammals, infected mammals for animal health and human health. We understand the new epidemiological context that we have, and we don't I'm talking about animal health. We don't only depend of the known migrations north to south, but also how the virus remains in resident bird populations and other species. This context brings concern to all of us, and we still have a lot to learn. Backyard birds is the common connection between low biosecurity, where we see the entry point for the virus to backyard fowl, and that backyard fowl can bring risk to those who are closest. These are common concerns. And on the next slide, given that we're running out of time, I'm just going to talk about surveillance. And to understand the complexities in surveillance from the animal health point of view for avian influenza, we have to look at all of these components. These are commercial backyard fowl, places that have good biosecurity. We have commercial production. We have the reproducers. They are the ones that provide the population for commercial production. We also have backyard fowl. And this is normally family production, small, medium size. There's low biosecurity, low technical capacity, and are usually outside of official veterinarian services raters. And maybe we're not even talking about producers, just holders, people who have their own animals and do not have the technical knowledge to recognize a problem and to know what to do if there is a problem. And then we have migratory and wildlife birds and other mammals. In every country, we have to have the ability to carry out surveillance and early detections in all of these subpopulations, combining passive surveillance, active surveillance, including serology and virology with molecular tests, risk-based approaches to optimize resources and to optimize the detection. We also want community participation and awareness raising in rural sectors, and of course, coordination with environmental authorities and the private poultry sector. And we also need to have adequate lab capacity. Angel, I have some more slides that have images, but I think we can overlook them given the time. This is risk-based surveillance in Panama. It's optimizing areas where we should focus active surveillance. The next one would be the surveillance plan of Brazil for the animal component. It's very comprehensive and complete. It's being reviewed right now. The next one is just to remind you that we have been working from animal health so that veterinary labs have sufficient capacity. So we've done several laboratory rounds in the last few years to make sure that there is this capacity. The last round was this year, and we just launched a report that included 20 countries. And this is to remind you that with PAHO and the University of Minnesota, we're developing a tool for early detection of avian influenza in wildlife birds. And this is our biggest gap, to not understand what is happening in this population. This can represent risks to animals and human health. So this tool will help us predict the risk of avian influenza. And this is all for me. Angel, thank you. Thank you, Manuel, for sharing your presentation with Gabriel, and all of this is very important, early detection and contention. So thank you very much. And we hope that after the following presentation, we will have some time to discuss. Right now, we have learned about the experiences in the United States about the responses to outbreaks of avian influenza. We've learned the risk assessment, the current situation, and their recommendations. We've also learned on the recommendations from the intersectoral recommendations, including early detection and the importance of the intersectoral concept in public health. The following presentation, we will have the pleasure of having Dr. Roxana Trejo and Emmanuel Chavira, that I'll stop sharing. That it's a really good to have them. They're an infection and control team from the ABC Medical Center in the city of Mexico, and they are in charge of infection prevention and control at a managerial and nursing level. Dr. Trejo and technician Chavira are representing the ASLACI Association for Prevention and Control of Infections, and it's a pleasure to read their information related to prevention and control for patients of avian influenza. Dr. Roxana, we leave you the floor, and Milena is about to share her screen with your presentation, and of course, I am here to help with anything. Go ahead, Dr. Roxana. Thank you, and thank you, ASLACI. Thank you very much. Can you hear me well, Dr. Angel? We hear you. Thank you, and I apologize. I am in a park right now. We're going to begin, and thank you very much for the invitation. We feel very honored in ASLACI and in the ABC Medical Center to share this information. We are gonna skip some slides given the information that has been seen in other presentations. Excuse me, I don't see the presentation yet, so please let me know. Yes, we have to have some patience. Maybe Milena, if you're having problems, just send me the presentation and I'll share it. Well, yes, thank you, says Roxana. We want to talk about what health institutions should be doing regarding what is happening around the world right now. And I think the most important topic is that for those of us who have many years in prevention and control of infections in a health institution, why specifically have had to address two pandemics, COVID-19 and influenza, and what we have learned, what we should reinforce in each institution to prevent any contingency, or institutions that are closer to places where you have birds, production birds, for example, or even wild birds. And that's why I think epidemiological surveillance is very important. We're going to skip this one. There's not much to say regarding this. I think this is a classification that has already been provided. it's been provided right now, and also in many other webinars from PAHO, we've talked about the structure of viruses and how the virus is built and the pathogenicity. So next slide then. Avian influenza surveillance, we've also heard about this, and it's interesting to learn what other organizations are doing, other organizations that work on animal health, how these organizations are structured to carry out epidemiological surveillance and microbiological surveillance. And we know that that WHO, PAHO, and each institution in each country through the Ministry of Health or health system should pay attention to what is happening, not just within the country itself, but next to the country, because the countries, or globalization rather, is imminent and we are experiencing it. So the transfer of products from one place to another, or the cattle that can travel, or products related to animal health, all bring risks. If we talk about avian influenza surveillance, this is similar to other zoonotic viruses. So related to the alert phases that have already been mentioned, we have to globally detect where we're at, and then individually in each country we would detect where we're at. And this won't just depend on health systems. Those of us who are in control, prevention control of infections, we have to pay attention to what is happening so that we can alert or launch our plan if there is an emergency. Even if it's just one case, we have to be prepared in the urgent care area to see how we're going to treat patients. And that is why it's important to know which phase we are in globally and in each country. Next. And we know that avian influenza, well, the reservoir are the water birds, poultry, and all of the animals that can suffer this disease, and contact to these animals can also produce risks. And we have observed how this has happened in many countries. In Mexico, where I live, we have already seen this risk, and of course Brazil too. And it's important to know how transmission works, and we have to differentiate this when we have a patient at the hospital, and we have to be able to do the analysis, epidemiological analysis, to see whether we are facing a patient that has this type of illness without confirmation yet, of course, but we have to act on probability or suspicion. And surveillance of respiratory diseases is very important, and screening is the way we evaluate a patient to see if they are complying with the definition of a standardized case. And that's why we have to have this very clear in our preparation plans. These operational definitions have to exist according to how to the declarations of PAHO, WHO, or the health system of the country. We have to pay attention to this so that we can establish all of these within our own health institutions. And the goal in a health institution is to have a local plan, a preparation and response to influenza plan that is local, in this case avian influenza. And this is important so that we know what we are going to do if we have one single patient or more than one patient. This idea of having a local preparation plan is meant to establish a route for management in an epidemiological emergency and the implementation of fundamental prevention and control measures. And this document, of course, can change depending on what happens or recommendations that are given in treatment of patients in an institution. For example, today we know that there is no human-to-human transmission, but of course this could change depending on the behavior of that transmission. But today, when we have a case, we should already be prepared for that. And the goal of having a specific preparation plan for each institution, a document that isn't just paper, that is also action, The goal is to have clarity of what we're going to inform. What are the phases if we have some sort of epidemiological emergency? How are we going to treat? How are we going to have timely and fast detection? The communications amongst the different areas. What are the guidelines for that preparation plans that all the healthcare professionals and institutions should know? How to manage this information? Of course, how do we provide security within the facilities, the hospital or the site where we are treating patients. And this operational algorithm that should be very clear for each health institution goes from detection and risk analysis. It also includes monitoring and evaluation planning. Planning is very important. We have to know the policies that we have today in the institution. Are there guides that can help us standardize this in the institutions? And of course, we have to see what our health system is doing. But if the health system in our country still doesn't have a plan, we can use global plans from WHO or PAHO to create our own. And once we have the policies and processes and the dissemination, training, and adaptation to areas, and we also have to have a official document, and we have to know what personal protection equipment we need to use in a contingency. And of course, we have to reinforce anything that we already know today regarding transmission. For example, standardized precautions have existed for many years, and these are the measures that we have to implement anytime we find a risk of contact with a fluid. And it's important to assess how much professionals in institutions are clear about these standardized precautions and how much this is truly carried out. And when we do an evaluation assessments, we have to evaluate how we do the precautions. This doesn't require an outbreak. We also do have to be prepared for a larger scale emergency. So in this document, we have to include, for example, personal protection equipments, what we're going to need in terms of materials. And we have experienced this through epidemiological emergencies. There has to be a result in the emergencies. And of course, we have to create improvements in the institution on how we're acting to do. And execution is related to awareness, training, drills. This is something that is very important. We should maybe do it once a year, and this would help us be prepared, better prepared. Now, within the preparation and response plan, we have to have very clear goals. We have to see who's going to participate in the team, and we don't have to be in a pandemic to do this. We have to today know which are the emergency teams in the health institutions and what we're doing day to day to see whether we have, for example, the materials, the face masks or an N95 or something else in case there are bioaerosols. How much do our healthcare professionals know when to use a high efficiency respirator when you have bioaerosols? Because maybe when we work in infection epidemiology, we know about that, but the people in the first line, are they clear on what type of respirator they should use, how to use it, how to make sure that it's working, and how to discard it too? I think this is very important, and that is why we have to have a team assigned to a preparation plan and not wait till we have an outbreak, but have it today. So the knowledge of the local plan for a pandemic or some sort of epidemiological response by decision makers is very important. Next. And well, it is also important to know a little bit about the clinical signs. We need to know about the incubation period. What is the clinical chart for avian influenza. This is important because the moment that a patient goes to an institution, we have several ways to go to a hospital, but most of them arrive at urgent care or even the consultations or office patient treatment offices. They all have to know about the probable or suspicious symptoms so that we can detect cases so that they can take the next step, which is taking samples, and of course be equipped to avoid transmission from this patient. Next. Something that I want to mention that is very important. You can see this algorithm for patient treatment, something that we should be reviewing today within the preparation and attention to patients. One is the personal protection equipment that today we have in the institution. Is it the correct? Do the professionals know how to use it? And we also have to review the triage or urgent care areas. Are they closed areas? Do they have ventilation? Are we able to control the aerosol load in that triage area? We have to review that right now. And of course, if necessary, and of course, if it can be carried out, maybe do an adaptation of the area so that we can have greater ventilation. So it's not just about EPPs or training. We also have to look at the infrastructure of the institution, all the way from the first point of entry, and this would be triage. This type, next slide, please. This type of flow that has to exist in each institution should be visible in the places that we're treating patients. Patients can be adults, pediatric patients. We have to be clear, and this has to be easily accessible information, easy to visualize. We do not have to have a saturation of information, just clear information. And of course, we have to disseminate this information so that this is a fast source of information so that we can prevent transmission risk. Next. This definition is very important. This can, of course, be modified depending on the behavior of transmission of avian influenza in Latin America. How will this change? Let's remember COVID-19, where we had to modify things depending on the places where there was greater transmission in the countries. And when patients arrived at urgent care, the triage nurse had to, or the admissions people had to check whether this person was coming from a place where there was an outbreak. And this would lead to a process that would lead to the clear attention map for patients. You can see the slide, and here what we're seeing is, sorry, I stopped seeing the slide. She stopped seeing the slide. Okay, here the definition that you're seeing, this definition helps us in triage so that we can have clarity. And this, as I was saying, can change. This can migrate. But if we have a definition for suspicion, this helps us provide timely treatment, but it also helps us avoid transmission to healthcare professionals. Next. And you can see the alerts that we have for the patients when we are categorizing with a high, medium, and low risk. And this, of course, this gives us a lot of clarity related to what actions we should be taking for the attention of each patient. And if you observe the differences that exist in low risk to high risk, then each one of them specifically refers to what we should be doing in managing patients, in managing our protection, and the use of personal protection equipment, and this would help us avoid transmission risks. Another important thing, and this adds to what we were saying, is, and we have mentioned this through epidemiological emergencies, and of course, one of them is related to contact. We can, amongst healthcare professionals and the risks that we can see in these animals that are in close contact, and this is also managed in this relationship between workers that have close contact with the animals, and also this is transferred to where we're working at, where in health, and this also has to be done in the health institution areas, and we have to have the space, of course, that is helping the patients, and this is why it's important to use these precautions based on transmission in contact and the droplets or aerosols. And if it's aerosols, we have to consider the use of some other precautions. Next. In case of sample taking, here it is important to land and the preparation plan on how these samples have to be carried out. The personal protection equipment that we should be using for sample taking, and what is the best way to take the sample so the sample can be valuable and not to have a loss in the sample taking. The management, who does the sample taking, and of course, who has to transfer and where it should be taken to, if it's within the institution in the hospital or if it should be taken to an external lab. This also has to be very clear in our preparation plan because each sample that is taken in these cases of suspicion is very valuable to be able to provide follow-up and to do efficient epidemiological surveillance in the institution and in the country in general. So here we have a image of how to take a sample, and this should be included in a preparation plan and also include the personal protection equipment that should be used and also the packaging, if we have the packaging or not, and how we should be working to have this and make sure that this sample can be valuable for us. If we are talking about personal protection equipment, well, we have already talked about the measures that need to be taken related to hand hygiene, the use of equipment, and today we are adding contact with a drop transmission or airborne transmission and the use of the personal protection equipment. We also have to define when we apply hand hygiene, if we do it at the end or when we remove the gloves, and then we have to remove other types of protections like a face protection and then others. So this has to be very clear in the response plan, and this response plan has to be practiced. And I think it is convenient, and all the guides say this. It's important to have this training in a workshop format to make sure that the healthcare professionals are very clear on how to handle personal protection equipment, how to put it on, how to take it off, when to apply hand hygiene, and this will help us avoid contamination risk when we are taking off the personal protection equipment. When we have contact with aerosols, we have to consider aerial transmission or airborne transmission, and this can happen when we do aspiration, tracheotomy, intubation. This is the moment during which we have to use some sort of different respiratory protection, highly efficient respiratory protection, and we have to teach people how to put it on, how to make sure that it's working. And these personal protection equipments, this is something that an experience that we gained in SARS-CoV-2, where we saw that sometimes the face mask wasn't completely secured and people were exhausted, so they didn't correctly secure the respirator. And if it's not secured, of course, there's a risk. So it is important to be clear on this. Standard precautions are something that we always have to incentivize. And for those of us who work in health institutions, sometimes we think that everyone knows standard precautions, everyone knows when to use them. But when you provide a training and when you ask people, what is a standard precaution? What does this red sign say where you have the measures? And this is where we have to emphasize that we have to have the initiative of reading these cards, disseminating the information in the cards, and making sure that the healthcare professionals understand the precautionary measures. Just like we need to make sure that they do correct hand hygiene and that using gloves does not replace hand hygiene, and that we also have to do hand hygiene after using gloves. All of this has to be very clear and it has to be practiced. Next.
And well, talking about this, we said that part of prevention and control always needs to incentivize the washing of hands, make it with water and soap or with an alcohol solution with alcohol gel with the correct percentage, and of course, making the diffusion and the incentivation of having people develop the correct technique as well as developing a respiratory hygiene. Respiratory hygiene, this technique that we have here, what is most important is a protector and social distancing, of course. Next slide, please. And while the route of the health system, talking about the reception or the assistance provided to patients, this quick reception of patients, is this something that exists in reference to drills? If we're able to detect correctly and soon how much a patient is in a waiting room. Right now, we're only talking about when the patient enters to the triage center, but no, this comes from the waiting room. How long does it take for them from the waiting room? What kind of diffusion are we developing in a waiting room in case we are close to an area where there is an outbreak and these birds, for example, also in reference to companies, how much is this being done in reference to reinforcement from the waiting rooms? What information is provided in the waiting rooms? Are these accessible from the main nursing station? Does the staff know the information, the area of reanimation? Does it have enough space to be able to put different providers? There's easy access to radiology, surgery rooms. That's why it's important to have this preparation plan, and it needs to be able to focus on the alternative route within the institution of the hospital. Something that is priority is that in case there were to be some kind of change in the behavior of the avian influenza, and if there was this between humans, how are we much prepared, or how are we prepared in reference to this, and how must this go beyond what we are living today? And that is why it is important that we start modifying this according to what we are observing. Next one, please. And well, in reference to supplies and equipment, apologies for the letter that is missing here in Spanish. It's basically about the equipments to monitor vital signs. Where are they located? Everything has to do with special services, personal protection equipment, and where everything is located at, or where we would need to locate it to be able to have quick access to patients. Another thing that is important. How much have we already established an area of cleaning of surfaces to avoid any cross contamination? How would we need to develop this cleaning of surfaces in case we have a patient in triage after they've already been assisted? What is the route that they need to follow to be able to get to a gurney or to a bed? And what do we need to do? What do we need to have around the patient? Next one, please. And this is also very important in reference to having assertive communication in case of a contingency or attention to patients, because there is always going to be the generation of rumors of wrong information. And that's why it is important to be able to have clarity in reference to how we will be communicating the information and what we're going to be providing as information to each one of the institutions. Normally, hospitals have risk committees, and these risk committees or anti-risk committees are different risks, 10 different risks, but one of them is the epidemiological risk. And we need to have clarity in reference to what the communication is going to be, as this was already mentioned previously in reference to the commands. We also need to include this within the health institution. We also need to have this equipment in reference to these kinds of risks. And the next one, please, just to be able to finish. It is important that we are able to, with this information that we have in each one of the countries, it is important that we are able to establish our own plan, depending on what country we live in, what today is the incidence in case of this avian influenza, and what information we have within the system to be able to determine this. Yours in the own health organization. And well, just to finish, we wanted to mention the current importance is stated in the fact that we need to be prepared in case of there being a contingency in each health institution and not the other way around. That to avoid having it arrive and us not having us prepared or not having a protection equipment, to have a multidisciplinary team, to have coordination of sessions in a structured manner, and to be able to see how we are working within the institution in reference to the resources, both human resources and also resources and infrastructure, as well as equipment, as well as input to be able to provide help to patients. Thank you very much. Dr. Roxana, thank you very much to you. It was a very complete presentation. It talks about triage, investigation, identification, response, and going on to preparedness for input, which is very important in reference to all of this personal protection equipment as well. Thank you very much. Everything has been very clear. Now, colleagues, again, thank you very much for your time. We have 15 minutes of time, colleagues, for questions and answers. Please raise your hand. And we will give the floor to whoever wants to ask. We see that there is a question here in the chat, which is about Brazil, USA. If you want to begin in reference to being able to establish this part. The question is as follows, and it comes here from Guatemala. If you want to take the microphone, go right ahead as well. In the experience of the USA and Brazil and the outbursts in the animal sector, when do you consider that we should notify this to public health from the suspicions of case of influenza in animals or until having the confirmation? How are we able to carry out the follow-up to the people that are exposed? Go ahead. Yes, a very good question. Like we said here, this is the $1 million question. And we've worked with many countries in the region in intersectoral events. The recommendation is to be able to work from the context. The majority of the countries choose that we have the results of the laboratory, and now I provide a report. Why? Because there are countries, you can just imagine we have thousands of suspicions attended. So in reference to being able to see this in reference to every suspicion of health and considering that when this is seen, we have avian influenza to be able to coordinate the work. Now, what happens in many countries and to be able to see this investigation, to be able to see if we need to gather information of exposed people, this is being able to be done by veterinarian services in many countries are stipulated this way. Another thing is when the context changes. In other words, I already have an outbreak. The next one, the predictive value that is positive is quite higher. It's most possible for it to happen because I know that something is happening in the country. And therefore, when I have this, we are able to start establishing this to public health. But just as general and for the colleague from Guatemala, also when it is confirmed, You're very good, Manuel.
Yeah, I'm happy to answer from our side of things. So I agree with what Manuel said. I think that when you have a lower index of suspicion, waiting until you have those test results coming in makes sense. But as you have outbreaks occurring and the index of suspicion is higher and it's more likely that they are avian influenza cases, then having that early notification is important. I will preface this by how this happened in the United States, specifically for the dairy cattle outbreak, is that we are local state rule, and so our state health departments are the ones that are going to be notified first, and then they notify CDC. So it's going from the bottom to the top. And so in many of the cases, what ended up happening was that the state ag learned about an outbreak, and maybe the state ag tested and had a presumptive positive, and then they gave a heads up to state public health, hey, we have a presumptive positive, you might want to know about this. And then that presumptive positive would go to the national lab for confirmatory testing, and that sample is not considered effectively positive until it gets nationally confirmed. And so we had this kind of informal state ag, state public health having conversations and being given a heads up before we had those official notifications. But as I said, as the outbreak continued and the index of suspicion was more and more likely that every farm that was suspected was most likely positive, those you might not have fully waited for the test results. And it took a little longer to do the test results if it was a state that had never had a positive case before, because they did extra sequencing before they would do that claim that positive confirmation.
Just to be able to complement, this is a report on a local level that has to do with the identification seen here, but there's also an international report as well, which is by sanitary regulation that's international, and that basically has to do with the fact that any kind of influenza that's non-stational would be reported, and the requirement here is to be able to confirm this when there is an avian H5N1 is basically of important origin as well. When considering that there is not yet the confirmation of any transmission between humans, and here we're able to investigate this, but like we mentioned, and like Dr. Trejo mentioned, this also definitely helps us to be able to see this evaluation of risks in the countries. There is here another part here in reference to the suspicion where we have a suspicion, for example, in an influenza that's not typified, where we're able to have a notification through the National Center of Influenza to the Global Network of Influenza, which is coordinated by a PAHO, where we're able to determine it as a different mechanism. And of course, this isn't the guides PAHO that we have here. Now, there is another question in reference to APC specifically, okay, and for Dr. Trejos. It says, Doctor, you mentioned here structurally in reference to the establishments, health establishments. What message would you give to decision makers for the preparedness in reference to this part? In reference to being able to see the attention in health? Go ahead. Yes, thank you very much. The way of including this in reference to being able to just not saying anything. I understand that this interdisciplinary team is included in reference to the decision making. This would observe this evidence in reference to being able to have this infrastructure, considering this part of what is considered to be specific. We can help to prevent the risk in reference to being able to see this part. And we must use this to be able to improve our preparedness plan. I don't know of you, but one moment it did happen to us that the transmission was as high in reference to the fact that we've stopped operating surgeries. We had a combined curve in reference to being able to see the occupation of the hospital and the infected patients when they would go beyond the capacity of attention, reference to attention of patients, we started to prioritize. I think that it's important that all of the directives are considering this preparation activities so that the structure of the plan is that is involved in reference to being able to create awareness for this end. It's not about just going and asking for this at the office. No, they need to be included in the team. Very good, thank you. There is a question from Ivan Vargas. Ivan, maybe you can put what country you are from because the context is important. And I think that this is considered here the declaration of a country free of influenza. The country is the declaration of countries are free of influenza in the case of farms and with cases of wildlife birds. Is it possible? Well, I don't know if Manuel wants to comment on this, but for the Animal Health World Health Organization, the condition of the country depends on the condition of the commercial farming and poultry. It could be a country that's considered to be free, but it has some cases in wildlife animals. This happened in Brazil in 2023, where there were cases in animals, so wildlife animals, but the country has continued with their condition of free because for this World Health Organization, this has to do with the commercial and poultry. And so here we have the condition later on that was lost this year. There has been an outbreak in reference to this part. I don't know if Emmanuel wants to add anything. Yeah, just to mention that in the case of avian influenza, there is not any official recognition. It's a self-declaration of the country. It prepares a series of informations. This is reviewed in reference to the Department of State, and here we are able to see that there's not an official recognition as it happens with other uh, countries in reference to what it is seen and recognized here. Okay, thank you very much, colleagues. Is there space for another question if anyone wants to use the microphone or put it in the Q&A section? I do not see any more questions or hands that are raised. So I think that we are going to conclude the seminar. Thank you very much for the participation of all of you and the excellent presentations of the panelists. Manuel, Gabriel, Roxana, Imelda, Ashley, Christine, representing their own institutions. Thank you very much. And again, of course, thank you very much to the interpreters and to the team here, regionally speaking, Milena, Priscilla, Georgette, and the colleagues of the epidemiological influenza team. We've learned, as you have just seen, this is a very dynamic illness that generates a risk that can be categorized depending of in reference to this being part. To this end, to this part, although there have been specific outbursts with affectance to mammals, and always there needs to be an evaluation of the risk that is continuous intersectoral to be able to reinforce this part seen here in reference to contention and to start preparing the services of cases in humans with measures, controls to remember that all of this and prevention of control is based on risk. And here we have the measures and the guide seen here as have already been exposed in the seminar. So once again, thank you. The seminar just complements other seminars in reference to detection, monitoring, clinical management, and intersectoral response. And this following seminar that we have are the results of the consultation of experts for the intersectoral response, which was also done at a regional level as part of the Commission of Influenza. Thank you very much to all of you. Have a good day, and we will continue working. Thank you and goodbye.